Great. So it's good to see almost 200 people online, and welcome to the first webinar in 2025 from ESSO. It's first of many more to come in the stream of breast cancer-related topics. Before we start the webinar, we have a few poll questions that we'd want to run by the delegates and participants. There's no right or wrong answer here. We just want a flavor for us to understand our audience better. So there'll be 3 questions at the start of the session, which will be immediately now. And then there'll be 2 more questions that come at the end, just to give us a flavor of how the webinar and the speakers have been able to sway your opinion and your thinking. So if we can have the 3 poll questions, Maria, please.
Yeah, you should see the first question now on your screen.
Yes, we can see that it's a very straightforward question. Is most of us, or all of us, should be practicing sentinel node biopsy? And which is the tracer that you use for sentinel node biopsy? So do you use technetium, isosulfan blue, SPIO or magnetic tracer, ICG, methylene blue, you use the dual technique, or any other techniques that you use? So encourage as many people as possible to answer, please. Yeah, if you use blue dye, that's fine. You can put other. Patent blue, we should have put there. You're right. So you've got 46% using technetium. Got okay. So we move on to the next question, please. And this is a very straightforward question. It's whether you've experienced any availability issues with technetium for auxiliary staging in the last year. And it's a simple binary choice, yes or no. Perfect. Can we have the answers, please? %62% have faced problems. That's great to know. And we've got 38% that have had no problems with procurement. Okay, so let's move to poll question number 3. And this is a very interesting question, which is, have you used the delayed sentinel node biopsy technique before? Usually this would apply to patients who are having a mastectomy for DCIS. Do you use any kind of injection to mark the sentinel nodes before you remove the breast? And again, binary choice, yes or no. Great. And can we have the answers, please? Okay. So 64% do not do the delayed technique, and 36% practice, and this may be about regional variation of and availability. So we've got an audience which is fairly split. Technetium is the tracer of choice, followed closely by methylene blue or patent blue and SPIO, interestingly. You've got the dual tracer at 34%, and then you've got 62% of you have traced some kind of shortage, and 64% of you do not practice delayed sentinel. Brilliant. Now, before we start, we have very good to see about 250 people online. We have a small presentation about ESSO, if I may. So Maria, if you can, just to give you a brief background about ESSO, because not everyone will be members. So ESSO as a society was established in 1981 to support its members in advancing the science and practice of surgical oncology. It's not just a breast cancer society like the ASBRS or ABS. It's across different specialties in oncology, and we have 4,000 plus members. Can we go to the next slide, please? So to advance science and practice of cancer surgery through various things like inspiring the younger generation, harmonization of education. As we know, we are trying to get breast cancer and breast surgery related recognized as a specialty across Europe. We exchange ideas. Recognizing surgical oncology as a specialty itself in Europe is a bit of a task. The multidisciplinary care approach, cure cancer together as a part of multidisciplinary team, education, research, and providing guidance to younger people. Now, we would encourage all of you who are not members to become members of ESSO, because you have then access to the ESSO, which itself is quite expensive to to subscribe as a standalone. Access to knowledge, webinars, various courses that we run, career growth, because we have educational grants, we have exchange programs, we have fellowships that our members have access to, research opportunities and guidance to develop, and of course, a global network of leading experts to act as mentors and proctors. And the next slide, please. So, date to save in your diary is, of course, our Congress, which is the 44th Congress for ESSO, between the 15th and 17th of October in Gothenburg in Sweden. And the dates to your left are important dates or milestones about early registrations, submission of abstracts, and then the deadline for early registration. And the next slide. So you can submit your research and contribute in all these specialties. It doesn't, but obviously we have a breast cancer audience, so you will focus on breast cancer. But if you have colleagues in your institute who are within this multi-specialty, please encourage them to look at ESSO as a possible venue for submitting abstracts and their research. And lastly, we have the next slide, please. We hope to see you all in Gothenburg in Sweden. So that's about ESSO. Encourage all of you to become members. ESSO website is usually a good place to keep abreast of all our educational offerings throughout the year. Now, I'm your moderator and host for today. I'm Ashutosh Kothari. I'm a breast surgeon. We have a very nice program with excellent world-renowned speakers, well-respected within the breast cancer community. To start off, we have Candice McGuire, who is from the Virginia Commonwealth University in Massey, Virginia, the United States. She's going to kick us off with the first topic of the day is Tc99, how much is left and how long do we have? The filler in the sandwich is none other than Professor M.Thill, a good friend and colleague from Germany, who's going to talk to us about alternatives to sentinel node biopsy tracers, logistical benefits of switching to these alternatives, and probably a bit about how to make a business case. And last but not least, another close friend and colleague, Mr. Magneto. Andreas Karakatsanis needs no introduction. He's done a lot of seminal research on this topic, and most of you have read his publications and meta-analyses. He's going to talk to us about how to improve patient outcomes by switching your sentinel node biopsy tracer. Just a note for housekeeping, if you have any questions, please don't put them in the comment section. Please put them in the question and answer section. We will try and answer most of them online, but if some of the questions are really good, we will try and answer them in person at the end. So we'll have the talks and then we will take the questions. Lastly, of course, on behalf of ESSO and the ESSO family, I'd like to thank and extend a big thank you to our colleagues in Endomag, which is never backward in coming forward to support educational endeavors across Europe and America and has been a good supporter for ESSO over the years. Thanks to their sponsorship, we are able to bring this webinar to you free of any registration fees. So without further ado, I would request Candice to kick us off with her talk. So the next 20 minutes are yours, Candice.
Absolutely. Well, thank you very much, Ash, for the kind introduction. I'm going to go ahead and share my screen here. There we go. Let me switch the settings here. Okay, so thank you all for being here this evening. And I do apologize. I'm just getting over a cold, so hopefully I do not cough.
You're on mute now, Candice.
Candice, you muted yourself.
I don't know how I did that. So thank you for letting me know. So I'm going to talk to you all about the standard tracers. Looking at the poll results, this is what most people are using internationally. And especially I'm going to focus on technetium-99 and some of the shortage issues that we've recently run into. So if you look, these are my disclosures. Just an outline, why do we perform sentinel lymph node biopsy? What are our current agents? What's going on with technetium-99? The various blue dyes that are available, and the potential future of sentinel lymph node biopsy mapping. So pretty busy slide, but as we all know as breast surgeons, breast surgery started as a maximally invasive procedure. So the radical mastectomy that Halsted heralded back in 1894 really wanted to remove as much of the local disease and surrounding normal tissue as humanly possible because we really had nothing else to give. And that approach persisted for several decades, almost a century before we really started to use systemic treatment and radiation to also treat patients with breast cancer, which then led to a de-escalation of surgical intervention. And so we went from our radical mastectomy with our axillary lymph node dissection of all 3 levels, down to a 2-level axillary lymph node dissection with a modified radical mastectomy with B04 in 1985. And then in 1994, Armando Giuliano began the use of sentinel lymph node biopsy using blue dye mapping for breast cancer. That's then been followed by several trials looking at various ways that we can de-escalate care in the axilla to the point where in some patients, we don't even check lymph nodes at all. But certainly sentinel lymph node biopsy is now considered the standard of care for axillary staging in breast cancer. So why do we do the sentinel lymph node biopsy? Number one is just to stage the axilla. This is not a therapeutic operation in most cases, but really you're using that staging information to guide your systemic therapy. You can minimize axillary surgery using the sentinel node staging. There are some who suggest that it debulks low volume disease. And also, especially in our patients who've had neoadjuvant chemotherapy or endocrine therapy, it determines the nature of that residual/resistant disease in the axilla, which is extremely important from a prognostic standpoint. So thus far, our standard agents have been technetium-99 in some form of blue dye. I've got isosulfan blue here because that's a pretty common one used in the US, but certainly there are many others that we'll discuss. If you look at detection rate for early stage breast cancer, it's pretty good. When these are some of our sentinel trials of sentinel node, B32, Almanac, and you can see that sentinel lymph nodes were identified in almost 95 to 99% of all patients. The false negative rate was incredibly low in most of these trials. Less than 10% has sort of become our standard. When you look at all of these trials, they hover around that percentage. And the accuracy of the sentinel lymph node biopsy was greater than 95% in all of the major trials that established sentinel lymph node biopsy as an acceptable alternative to axillary lymph node dissection for early stage clinically node negative breast cancer. Even if we look at sentinel lymph node biopsy detection rate after neoadjuvant chemotherapy for clinically node negative patients using a variety of combinations of blue dye and radiocolloid, you can see that the identification rates are still quite high in most cases, high 80s to mid 90s detection rate. The false negative rate still hovers around that 10%, depending on which trials you look at. So obviously the combination of radiocolloid, technetium-99, and some form of blue dye is incredibly effective and safe, the use of sentinel lymph node mapping for breast cancer. So looking at technetium-99, where did it come from? We all sort of accept that it's been there from time immemorial for our use. But really, the discovery of techneto from the Greek I'm gonna butcher this. I'm not even gonna say it because Andreas will kill me. So it came from a Greek word, and it really meant artificial. And this was attributed to Carlo Perrier and Emilio Segre. who discovered technetium-95 and technetium-97 at UC Berkeley in 1937. They found it in some samples of molybdenum, which had been irradiated with deuterons in the cyclotron of the UC Berkeley lab. Now, for a long time, technetium was really just considered an exotic artificial element, and not too much attention was paid to it. This changed, however, when 3 investigators at the Brookhaven lab in 1958 discovered technetium-99, the generator, and found that it had very favorable properties for use in nuclear medicine purposes. So here you can see Walt Tucker, Jim Richards, and Margaret Green, who all had a hand in bringing technetium-99 into the clinical realm. And so clinical exams really were based on technetium-99 from then on, and it still outperforms the use of PET agents. So not many of us really think about where technetium-99 comes from and how it's produced. It's produced by a radioactive decay, as I described before, and it's currently made in nuclear research reactors through the fission of enriched uranium. 99 molybdenum, which is the precursor to technetium-99, is loaded into dispensers called generators, which are then shipped to the end users, which are the radiopharmacies. A generator typically lasts 1 to 2 weeks. It cannot be stockpiled because of this half-life, and the production of technetium-99 is easy, it's very fast, and it's relatively inexpensive, but obviously it does not last long once it's produced. The benefits of technetium-99 are pretty obvious to most of us. The short half-life is kind of nice. It's got a half-life of 6 hours. You can give it 24-hour, an injection up to 24 hours prior. However, 94% of the radioactive signal will have decayed in 24 hours. It's low energy, so the pure gamma emission of the energy is equal to about 142 kiloelectrovolts, which is fairly low energy and very safe for the end user. There's low dose to tissues, meaning it's safe for patients while maintaining good detection. So it has scarce attenuation into the tissues, which allows for a low dose to the patient while still maintaining good external detection, not only for image generation, but for detection with a probe. Now, as radioisotopes decay within hours or days, it makes them vulnerable to short-term disruptions to supply because they're only good for 1 to 2 days. You're constantly re-upping your supply. Now, the most commonly used isotope, technetium-99, accounts for over 80% of diagnostic nuclear medicine procedures. So not only are we using this for sentinel lymph node biopsy, but we're using it for bone scans and several other nuclear medicine procedures that are really quite vital to patient care. Now, any disruption to this supply network significantly impacts the availability of technetium-99. Now, what's interesting here is if you note the HFR reactor here located in the Netherlands was due to end operation in December of 2024. And this reactor actually was supplying 38% of the global technetium-99, which became a major issue, as we will see in a couple of minutes here. So there has been some mechanical issues at a reactor in Belgium, which coincided with the scheduled shutdown of the Dutch reactor, and that led to a steep drop in supply and global concerns in November of 2022. Now, again, supply issues from the shutdown of the Dutch reactor and the Maria reactor in Poland led to a drop in supply and global concerns in October of 2024. So during this time period, only 40% of the required technetium-99 was available compared to normal global demand. So not only are supply issues a concern, there are other limitations to technetium-99. So radioactive drugs must be handled by a dedicated department. It's got that short half-life of the tracer, so the injection has to happen the morning of surgery or the evening prior. And this can cause scheduling issues and often result in delays to operating lists or schedules. So usually this is not a patient who's going to be your first patient of the day. So that can create an issue with scheduling. If you work in a place that doesn't have a nuclear medicine hot lab, you're not going to be able to do sentinel lymph node biopsy in that setting, which can be very important for people who are looking at operating in small hospitals, outpatient surgery centers, or other rural sites. So looking at the increased security of supply, this could be achieved through several measures. We could look at reducing technetium-99 use, looking at alternative methods of staging patients, looking at alternative methods to use it for bone scans or other detection within the medicine realm. So PET scans, things like that. Looking at the accelerator production and bumping that up, investing in new reactors, which would support the market, which is ongoing, and using alternative tracers for some clinical requirements. So that's technetium-99. It looks like many of you have had issues with supply, and you know how difficult that can be when you're trying to treat patients. What about blue dye? It's a great alternative. It's also a great, combination component if you're doing dual tracer. How does blue dye work exactly? It binds to albumin. It's absorbed into the lymphatics, and then it migrates to the lymph nodes, and that's how you detect your sentinel lymph nodes. The positives to that is it's a small particle size and it enables rapid migration. The flip side to that is it doesn't necessarily always stop at the sentinel nodes and can continue to migrate to upper echelon nodes. And after a few hours, all blue dyes are essentially completely washed away from the axillary lymphatics. As many of you noted, you're using a variety of blue dyes. So patent blue V is the dye that's most recommended for sentinel lymph node biopsy in the UK. Isosulfan blue, which was the first one used for sentinel node with Dr. Giuliano back in 1994, is often used in the US. Methylene blue is nice. It's inexpensive, but it may cause necrosis and is widely used in many countries. And then indigo carmine we see a lot in China and other Asian countries. So what about blue dye in combination with radioactive isotope and blue dye alone? So you can see here in several trials that the blue dye detection as compared to radioisotope is slightly lower. So radioisotope detection rates are usually in the high 80s up to high 90s, whereas blue dye can be slightly less. Many times this has to do with what blue dye you're using and what technique you're using. But blue dye alone sometimes is not an adequate way to stage an axilla. So let's take a deeper look at some of these blue dyes. So we've got patent blue. And this has been evaluated in several studies, including the Almanac trial, has a very low risk of adverse reactions, less than 1%. Severe grade 3 reactions are extremely rare. Even in systematic review, you can see that the rate of anaphylaxis is 0.083% in breast cancer. It's a low volume dye that you're injecting. You usually do it in an intradermal method, and those, again, are both associated with lower rates of anaphylaxis. Isosulfan blue is the OG, if you will. It's the most anaphylactogenic, however, amongst the blue dyes with a rate of 0.16%. It's also extremely expensive, which a lot of people don't recognize. So one vial can cost upwards of $1,000. Certainly for those who have experienced the anaphylactic reaction to one of these blue dyes, it is something that you will not forget and that you hope to avoid in future practice. Methylene blue dye is a really nice alternative. It is much less expensive than isosulfan blue. It's easy to obtain in most countries and can be used in sentinel lymph node mapping. When you use it in combination with technetium, the identification rate in a meta-analysis was 91%. False negative rate sits around 13%, which is a pretty high false negative rate according to the American Society of Breast Surgeons recommendations. Caution is warranted when using this alone as the mapping method for sentinel lymph node biopsy because of that high false negative rate. And also, if you inject it in an intradermal method, you can and will cause skin necrosis, which I've also seen. So adverse effects of all the blue dyes, they can cause staining. And especially if you're injecting intradermally, you will see a stain that can last anywhere from days to weeks to months. So in studies performed in that were reported in Breast Care and the European Journal of Oncology, 36.5% of patients injected with blue dye had residual staining at 12 months. And in another study, it was about 41% of patients. So while we perceive that this is a very short-term, short-lasting side effect, many patients will see this blue staining persist for several months. The other big problem with blue dye is its genotoxicity. So this cannot be used in pregnant patients because it's genotoxic, and that applies to patent blue, methylene blue, and isosulfan blue. Now, this has not been trialed in patients. It's all in vitro data, but in concentrations similar to those used clinically, we will see genotoxicity. So that leads us to think about the future of the mapping agent supply. What are the ideal components of a new alternative? We want something that doesn't have supply chain issues, perhaps something with a longer half-life, fewer regulatory burdens, lower risk of anaphylaxis. And obviously, you're going to want something that's just as good as the gold standard, something that's non-inferior to Tc99 and blue dye. So I'm going to hand this off to my colleagues, and I thank you for your time and attention, and I welcome any questions.
Thank you, Candice. That was a wonderful presentation on the manufacture of technetium, which not many people know from where it gets to us. And then, of course, your data on blue dye and everything else was fantastic. So that leads us nicely on to our next speaker, Professor M.Thill, who will talk to us about alternatives, which Candice has touched upon, but more detail will come. So, Mark, over to you.
Yeah, thank you, Ash. Thank you to the ESSO for inviting me. I'm just prepare my slides. And here we go. So I'm very thankful that Candice covered a lot regarding technetium and blue dye, and maybe I'm able to add some more informations, but I want to mainly focus on the other alternatives like ICG and McTrace. So these are my conflicts of interest, a lot of cooperations with different companies. I'm a gynecologist, by the way, so maybe sort of the elephant in the room. So, and therefore, I'm presenting always our German treatment recommendations by the AGO, Breast Cancer Working Group. So this is the Association of Gynecological Oncologists. And as you are able to see, this is how we recommend what we are currently doing regarding sentinel lymph node marking. And you see that technetium is still the standard of care, but we heard a lot about the obstacles and about disadvantages. But regarding the data, we do see level of evidence 1A, Oxford grade A, and AGO, the highest recommendation grade with the double plus. But you're also aware of that patent blue dye alone has a plus-minus recommendation, and then the newer marking methods like ICG or superparamagnetic iron oxides like McTrace, they have a single plus, and this is something that will be upstaged, I think, with the more data we get. So as I said, for technetium, Candice really covered a lot. We can say it's the previous standard of care, but we do have very, let's say, easy equipment. So this is, but regular and costly maintenance is necessary. But all of us know that it's very easy to manage, very easy to handle that gamma probe. But of course, about the cons, I think I'm not able to add anything else. We do have limited availability. In Germany, we had last year 6 weeks of missing availability because the main reactors were out of service. And this is something that really bothers us and, of course, our patients. And this is the reason why we are working now for the last 4 years in daily routine with other techniques I want to talk about later on. Regarding patent blue, I mean, we have one big advantage, like for all the markers or marking techniques we're able to use on our own. We have an independence from nuclear medicine. We have some cons like the low detection rate and the high false negative rate tattooing was mentioned, no quantification, and the risk of anaphylaxis. And then talk about pregnancy, what to do, and what to do regarding breastfeeding, because we do have breast cancer patients who are pregnant, and the only data we have at the moment coming from technetium, and we have no patent or methylene blue dye recommendation due to anaphylaxis. I want to show you one paper on the next slide, and we have unfortunately no data yet for SPO or ICG. And I think this is something we have to take into account when we talk about pregnancy, that we do have a 2% risk of an anaphylactic shock after injection of blue dye. So therefore, there is no need for any recommendation for either patent or methylene blue. Yeah, coming to methylene blue, that was stated already. So when I was traveling around the world doing some surgery, I found methylene blue very regular and frequently used in China, for example, other Asian countries, in India. And we have, again, an independence from nuclear medicine. It's cheap. I don't want to say that just being cheap will lead to the use of developing countries, but of course, you are able to lower the cost. Again, no quantification. We have a risk of anaphylaxis, but it's quite low. And then, of course, my colleagues in Candice and some paper, they observed and they talk about, and I summarized some skin necrosis or structural parenchymal changes. But if you review the literature, and this is what I did for the talk, I mean, you find some publications, retrospective data collection, cohort or case control studies, but all of them, they all say no adverse events, not really safety problems. So therefore, I think this is something that is able to be used in the developing countries because of the lower price. Of course, we do see anaphylactic reactions, but this is a meta-analysis, and honestly, for breast cancer, we do see an incidence of an anaphylactic reaction in 0.083%. So this is very low. It's not an invitation to use methylene blue in daily routine, because I think we have other techniques that are much more recommended than methylene blue, but it's an option. So coming to ICG, and this is something I'm really excited because this is another technique that can be used on your own. You don't need any additional visits, for example. And this is based on a water soluble tricarbocyanine dye. It's a fluorescent under near infrared light when you use different devices, and it's excreted via the hepatic way. So we do have some pros, again, independence from nuclear medicine. We have low cost for the tracers, but of course, some expensive equipment is necessary. And at the end of this talk, I want to provide some calculations, some prices, but of course, regarding the different countries that are listening tonight, we do have, of course, different healthcare systems, and this is just a German view, but this comes to the end of my talk. We have some challenges using ICG, because if you are damaging lymphatic vessels, and this is maybe you are remembering when we all started in 1998, so this was my first sentinel biopsy I did. We had to find the blue track, and we had to make a very proper preparation of the lymphatic vessels. So this is something you have to do by using ICG, because otherwise, if you damage the lymphatic vessel, then you have a contamination of the whole surgical field. Surgery must be carried out quite quickly. So maybe it's not that learner operation or learner surgery. Deep lying sentinels are difficult to find. So from my own experience, and I did quite a few procedures with ICG, it cannot be recommended really for high body mass index, because the signal depth has a maximum of 1.5 centimeter. And then with some cameras, but I think this is dependent on the equipment and on the price you want to pay. You have to darken in the operating room, and there's no quantification, but there is one one exception, there is one device called the Europrobe you are able to use, and it will give you like a gamma probe you use for technetium. It will give you a quantifiable signal by using that probe if you perform the ICG method. Then, of course, and this is something you may have to take into account, that we don't have an FDA approval. We have an EMA approval of the ICG tracer, but for breast cancer only in Spain. And then we have an approval in Japan and in China. And this is maybe quite ridiculous because as I'm a gynecologist, I was trained in obstetrics as well, and we used ICG for many, many years for Gemini diagnostic. And then Candace covered a lot of data, so therefore I don't want to stay there for too long. So there are network meta-analysis telling us that SPIO or ICG alone are superior to blue dye, well comparable to standard dual modality technique of blue dye with technetium. And this is something that we find in the literature more and more often, that we do see an equivalent effect of ICG to the radioisotope and superior to the combination of blue dye and radioisotope. So, but all in all, I mean, these are different publications, and they cover that there is at least equivalence, and you don't have to have concerns to find more lymph nodes than needed, or a lower detection rate, for example. So this is nothing you have to have concerns about. For the reason that I'm a gynecologist, I use ICG in daily routine when I perform cervical cancer and performing systemic lymph node excisions. So this is these are some impressions when I'm sitting on my robotic system. So this is quite nice to change to the Firefly mode using the Da Vinci system to use ICG. But also for breast, so this is an impression from my OR using a system where we're able to not darkening the OR and nevertheless being able to identify the fluorescent tracks from the injection around the nipple areal complex, and then you find the lymph node. So what I would always recommend is you see there is the vessel, and then the vessel disappears somewhere here, and then you have to make your incision 2 centimeters far away. And this is the typical position for the sentinel that you are that you know from all the procedures you did in the past. And then, of course, you have different modes. So you are able to show where is the maximum of the ICG to identify not too many lymph nodes, for example. So this system has a mode that you are able to see this reddish center. So this is the real sentinel. And if you have like different fluorescent lymph nodes, you're able to identify and to differentiate between the different lymph nodes to identify the real sentinel lymph node. So this is one of a short impression, so a short video how to inject it, and 2 little injections here, and then you're able to switch with this mode. So this is a Stryker system I'm using in the OR, or I used in the OR because I was interested in to do that. We will make a study in the actual year, and then you are able to identify where to put the lymph, where to put the injections, and then of course how to identify the lymph node in the end, as you are able to see in the axilla, and there you see this is the red signal. So therefore you are really able to identify this is the real sentinel. All right. Coming to the next alternative, so the superparamagnetic iron oxides, or in short version, SPIO or SPIO, as we say in Germany. And I was in contact with this technique in the early days in 2012-13. So we did the first European or Central European Centimax study. In these days with 5 milliliters of the tracer. So today we use 2 milliliter, different formulation. These days we had to place it directly behind the nipple, 5 mils. So this was quite a lot, but the study was very successful and published in 2014. And we were able to identify a similar detection rate when compared with technetium. And we identified a tiny bit, tiny less lymph nodes. And I always had the idea that the identification of the lymph nodes was more precise when compared to technetium, because you never had a shining through effect you sometimes have with the gamma probe. So I don't know whether you have the same experience, but sometimes our nuclear medical department is injecting the tracer, and then with a gamma probe, I find the patient, but I don't find my lymph nodes because the dose was too high. So this never happened when I used Sienna Plus or MagTrace I'm using right now. So MagTrace is a super paramagnetic iron oxide particle, as I said, in a carboxydextran shell. It's very harmonized regarding the size of 60 nanometers, so more homogeneous when compared to technetium, for example. The detection is done with a Sentimag probe. So this is a magnetic a probe that is able to magnetize the iron suspension. So you have a quantifiable magnetic signal with this console you're able to see. And as asked in the beginning of our webinar, quite a few of you use MagTrace in daily routine. So a big advantage regarding the ICG is that we have an approval for all solid tumors, CE marked, and FDA approved. And in Germany at the moment, so you may know that we have around 230 certified breast cancer centers, and approximately 80 certified breast cancer centers are using MagTrace in daily routine as the only solution. And they're really happy with that, because they don't have to send patients to nuclear medical departments as they have no accessibility in their own department, for example. We do have some pros. Again, the independence from nuclear medicine department. We have, I think, a maximum of flexibility for the surgeon. We have no signal loss, and Andreas will talk about later about the delayed sentinel biopsy, a great technique that was published by him. So we use this in daily routine. So therefore, be excited for the talk after my talk. You were able to inject 30 days to 20 minutes before the operation. So therefore, when we talk about logistic benefits, then you are able to introduce what we say marking days in your department. So if we invite the patients one day, we do the injections 2 weeks, maybe 3 weeks before, and then you are able to cover all the patients regarding the sentinel biopsy. And for the reason, so this is something that happens in Germany at the moment, that we are restructuring our healthcare system, and we want to get rid of patients staying on the ward. So we want to have an outpatient setting for the patients. And therefore, every additional visit that can be avoided is, of course, beneficial for your own standard operating procedures, for your logistic, but for the patient as well. And then you are able to do surgeries on Monday or after public holiday. So as I said, the maximum flexibility. We have a quantifiable magnetic signal. We also have a visual orientation. As you see, there's a brown color when the lymph node is capturing the SPEO, and we have a very good tolerability of the tracer. The probe does not need any maintenance when compared to the gamma probe. Of course, we have some cons, but I would say at the moment, because there is another console out, and this is approved in the States. To my knowledge, we did a study with a new console, with a new probe. So this is coming in couple of months, I think. So that will be introduced in the market. And with a new console, with a new probe, you don't have to use plastic instruments in the operation rooms, what we use at the moment. But honestly, so this is nothing that has something to do with costs. Tattoo, yeah, can be can occur, but yeah, injected not too superficially. I will show you a video in a couple of moments how we do the injection. We use 2 mL of McTrace, so this is the current available dose. And yeah, and then we have to talk maybe about MRI artifacts, and Andreas Karakatsanis, so that the last speaker is working on that issue, and I hope that he will publish as soon as possible some data that we are able to get rid of the MRI artifacts by injecting the McTrace just behind the lesion and then excise the lesion and the McTrace. So therefore, we are able, hopefully, to avoid any artifacts in the future, as shown on this little image. And yeah, you see the white this artifact here, so the black hole. This is yeah, this is German, but this is understandable very easy. So what we are doing when we perform our marking days, we put the 2 mL of McTrace yeah, by injecting the breast, and we do this ultrasound guided to identify the lesion, and you are able to visualize the tip of the needle, and then the injection follows. And the idea is to yeah, place the tracer in the surgical field, followed by the yeah, excision of the lesion and the tracer to avoid any residuals there. And then, of course, the detection is very easy, and there you are able to listen to the sound. So you hear this very beeping, yeah, and then be able to identify at the console the quantifiable signal. So very easy, what and something you are used to when you use the gamma probe and the technetium technique before. Of course, there is some data, SPIO versus radioisotope plus minus blue dye, and again, detection rate is not just equivalent, is consistently higher than in the standard of care, coming from this meta-analysis consisting of 436 studies. So therefore, I think this is now understandable why we say in Germany, SPIO is recommendable with a plus in ICG as well, despite this is a German slide, so I'm sorry for that. So when we talk about different techniques, of course, we are always very interesting in costs in Germany, because we have to, we get one amount of money and for every case, so therefore we have to calculate all the time. So this is, as I said, the German view, so you may have other costs and other prices, but what I want to tell you is that technetium is a very expensive technique, and if you're not aware of, because you're working in a hospital and your hospital management will tell, well, this is something we have to do because we have a nuclear medical department in our hospital, so this is something you don't have to calculate. Yes, but this is something you have to calculate. And if you see for 100 cases in the beginning, technetium is expensive, SPIO is less expensive, ICG is even more expensive regarding the expensive equipment, but this is a calculation, for example, for a department having 350 cases, and there you see technetium will stay very expensive, and the alternatives like ICG or SPIO that we use in daily routine is much cheaper, and this is something I think you have to take into account in this verse to make your own business case, to make your own considerations. To sum up, we did a question, in the poll in the German Certified Breast Cancer Center. So this was published in 2023. We are preparing a new pole, but you're able to see that there is some movement away from the only radioactive tracer. So 88% of the participants, they said, well, we do only take technetium, but you see SPIO 14%, ICG 3%. So this was a beginning, and I think when we reproduce the next poll, we will do see different results. At the moment, I think MagTrace is the technique that is the most promising technique. We do have a lot of data. It's very easy to handle. So therefore, this would be my summary, that we need a more flexible management, that we need independence of technetium. So therefore, make your choice regarding the alternatives. And with that, I thank for your interest, and we'll take your questions later on in the discussion.
Thank you, Mark. That was a great talk with lots of choices and lots of solid data and evidence. It was good to see that video, which you actually injected when the patient is awake, because one of the questions was, can you do this when the patient is awake? And I think your video answers that. She tolerated it quite well.
Yeah.
So we then now move on to our next speaker. Again, who needs no introduction. Andreas is from Uppsala in Sweden, and he's going to talk about how we can improve our patient outcomes by switching our sentinel biopsy tracer. So over to you, Andreas.
Thank you very much, Ash. Thank you, Candice and Mark. I think this was a very nice and relevant layout of how things are right now and what we are dealing with. I will just share my screen, and I would just like to say that I have a present for Mark, the MRI artifacts thing. So you see my tracers, you see my slides. These are my disclosures, and I would like to just set the frame with discussing how you start implementing change in practice, because what we want is that we want something that is data supported, and the higher the level, the better. Of course, you need to have a good word of mouth, so you need to have outside trial, external validity, good experience from peers, and to have good support in the evolving discussion of how all these techniques can evolve to meet new patient needs and new techniques that become relevant with time. In reality, at the same time, you produce evidence, but apart from the answers you get, a trial will generate new questions, and that would lead to a technique optimization, unmet patient needs, and as well ease of implementation, because doing things in a manner that is easier and more pragmatic for us is something that facilitates healthcare access and, in the end, healthcare equity. And, well, actually, we need all of the best without any of the bad, if that is possible. Fortunately, again, we do not need to reinvent the wheel. The ideal framework that was established some 15 years ago suggests a very good way of building innovation and driving that, and what is the type of studies we need to support that, and what is the level of evidence that we need in order to be able to move forward. So let's look at the data timeline. This is a little bit more personalized, because I would like to kind of share how I came in contact with non-isotopic tracers and how that came into my professional life as a clinician, but also as a researcher. So for me, it started back in 2014 by reading the Central European Sentinel study by some M.Thill, and that was a prospective multicentric and multinational non-inferiority study on a paired design. So a paired design means that patients that were undergoing sentinel lymph node biopsy were getting both the MAC trace that was called Sienna Plus back then, and the isotope. And there was a very clear comparability. So this was a study on a non-inferiority principle, but you see that the numbers are very, very self-illustrative. And that was the time that we were actually doing the Nordic trial with the same platform. And that was my first, and having the advantage of not being first in that, we could, apart from doing the trial, we could also perform a meta-analysis of a total of 7 studies at the time. And that was very helpful because they were built on a very, very similar protocol platform. So we are talking about studies that were performed on a paired design with the same primary endpoints, same technique, and that allowed for very, very confident results. So already back then, we knew that we had something that methodologically performs non-inferiorly, but in reality, completely comparable in terms of detection rate and in terms of nodal yield. With extremely low discordance, and the discordance is, mind you, something that you could evaluate only in a paired setting, because you do not need your new tracer to find any node. You need to make sure that you find the correct node. And since the correct node is what by default we accept for the isotope, since we had a risk difference of 0, we knew that this is a very, very safe bet, if I can put it like that. So that was what we knew back in 2016. And as Mark highlighted, back then it was called Sienna Plus, and we were doing 2 mL of SPRIO diluted with 3 mL of natrium chloride. The Senti Magic trial, which is in that generation, was the first one that used it without dilution. But we were doing subareolar injections, and we were doing it on the day of surgery in the theater, massaging the patient for 5 minutes. At the same time, we started looking at the possibility of doing a comparative head-to-head trial, and this is where the MONOS study came back, and it was a prospective double cohort that was carried out in 2 hospitals, one using the isotope and the other using the MAC trace, in which blue dye would be added only in case of uncertainty. This was a sort of randomized control trial, because the way we did the study was that we flipped the coin on who does what. What we found there was that there was comparable outcomes with regards to Sentinel Lymph node detection, somewhat fewer nodes with MAC trace, but that was not statistically significant. But what we also found out is that we could inject MAC trace before the day of surgery, and that had significant logistical benefits, and it translated to less money, because the time that you were saving from the 5 minutes of massage and the 20 minutes of waiting was the time that made surgery shorter and hence cheaper. Moreover, we could look into the discussion of skin discoloration, but we shifted during the study towards a peritumoral deep injection, and we found that these were the patients that had significantly less skin staining, and when they had it, it was less in surface and size, it was less pale, and it would disappear quicker than when we had done a periareolar injection. This is a little bit something that looks in a more recent publication, but it is the same logic. It is a single center randomized control trial from Hong Kong, where they had very, very high detection rates, and then they had similar nodal yield with very high concordance. So this head-to-head comparison was also a little bit later on in time confirmed in a randomized setting. Now, with regards to dosage, once we went from diluting to non-diluting, what we wanted to explore was the outcomes of lower doses. And this is the Sunrise trial from Isabel Rubio, a single center trial where they randomized the different doses, and all the patients took the isotope. The results were very reassuring. All the injections, on the other hand, were subareolar on the OR table with a massage, and the skin staining was reduced with a lower dose, but still it was higher than what you would get with a peritumoral injection. So our group came back and looked in all these factors at the same time in a sequential trial design, which was the Senti-Dose trial, which was a prospective multicenter dose study in Sweden. And what we did is that we had a cohort that would take 1.5 on the day of surgery subareolar with the massage within 24 hours, actually, and one that took 1 ml, both peritumorally and periareolarly, without massage, 1 to 7 days before surgery. The results here were very interesting because whilst methodologically we confirmed that what we were going for, which was non-inferiority against the isotope and against the nominal value of detection rate per the previous 2 ml dose, what we found is that the 1 ml actually had very, very good performance, and you could avoid any background signal from the SPEO in the lymphatics, because since it had been injected days before surgery, what SPEO was not retained in the node had been washed away, and you had beautifully brown nodes for that. And moreover, we verified once more that the discoloration with the peritumoral injection was significantly less. That led to what I think is kind of the second generation of how we are looking at things. This is a very large meta-analysis that was performed with very strict methodological timeframes. And what we found was that Sentinel node detection rate with a magnetic technique was approximately 99%, and that was not dose dependent. We also found that the injection window could be very broad, and decreasing the dose would not affect that. So time beats dose in terms of efficacy of outcomes. We found by looking at the literature that health economics had the potential to be optimized, and that a deeper injection would actually be able to affect the issue of dermopigmentation. MRI artifacts that had started being discussed back then had been done in the context of retrospective single-center reports that were more or less descriptive. So we pulled them, and what we actually saw was that there was a very clear connection of artifacts with SPEO remaining in the breast, given the fact that a very small case series from the Netherlands back then that had tried the intratumoral injection had no artifacts. So a hypothesis that we had already been doing and exploring in a trial, the post-MAG MRI that I will be talking about, looked like it was going to be verified. So the status of knowledge was that it is completely comparable as a sole tracer to the isotope. Smaller doses will work as well. The preoperative injection in meta-analysis worked better over the double tracer. It enhanced detection rates. The peritumoral injection worked better for dermopigmentation, and you could combine MAG trace with the MAG-seed if you needed lesion localization. And that was something that we felt was important, because the only other alternative with a single platform possibility is actually if you go with a radioactive seed and radioisotope, but we wanted to leave that behind us. And with regards to the single platform, we actually performed a randomized controlled trial that compared the MAG-seed with the guide wire in patients undergoing sentinel lymph node biopsy with SPEO. And what we saw over there is that the MAG-seed was more advantageous in terms of outcomes over the guide wire, and this has been published last year in JAMA Surgery. But with regards to sentinel lymph node outcomes, we still had very high outcomes, very high detection rate, a median of 2 nodes with an interquartile range of 1 to 3, injected a median of 7 days preoperatively. Mind you, the MAG total was a pragmatic trial that, which meant that we allowed for variability in order to be able to see whether different practice patterns had an impact on outcomes, and they did not. So what we did in the trial environment was something similar with what Mark has introduced, that we were using preoperative single localization sessions in approximately 86% of patients. So this was completely decoupled. The patient could go to radiology, or they could come to surgery, and we would deploy the marker and we would perform SPEO injection, and that was on a completely different day than that of the day of surgery. So delayed start of surgery or logistical challenges were not an issue with this strategy. What we also found that was also in alignment with the rationality of the post-MAG MRI study is that if you inject SPIO at the part of the breast that you are going to remove, then you should not expect any artifacts or any dermopigmentation. And we actually saw that the dermopigmentation, once one had done a focused injection of SPIO, was the lowest ever described. It was on the range of 8%. Now the post-MAG MRI study dedicated to Mark, because we have had discussion about that. So that was a prospective observational study of patients that had undergone magnetic sentinel lymph node biopsy using 2 1.5 or 1 ml of SPIO injection, where patients that had signal at the resection cavity after resection were followed prospectively with transcutaneous counts and MRIs. Mind you, what we wanted to do is that we did not consciously remove the entire SPIO footprint. So we consciously left MAG trace back in the tissue to see whether removing the bulk is enough and how these things interact. And to spice things a little bit up, we assigned 4 radiologists, independent and blinded to treatment, that would review the MRI and the synchronous mammograms without knowing what the others have said and without knowing what we had done in surgery, or if we had residual signal, or if we had skin discoloration. And more or less, the interesting thing over here is that is not depicted in the slide, is that in a weighted frequency of approximately 20% of SPIO artifacts, there was only one rater in 1 of 159 MRIs that felt that image interpretation was affected. And interestingly, since we asked them to score the difficulty and the artifact prevalence in both the mammogram and the MRI, the mammogram scored 1.5 out of 10 and the MRI scored 2 out of 10. So that means that removing the MAG trace injection site when you have done a peritumoral injection will effectively reduce MRI artifacts as a concern. And at the same time, since this was a study that had a span of 5 years, in these 5 years we had 6 patients that presented with a recurrence, and the recurrence was diagnosed at MRI regardless of whether the raters that were reviewing the MRI had found artifacts, yes or no. So that issue has been now resolved in a study that is dedicated especially to this. With regards to delayed sentinel lymph node biopsy, or Sentinel, our baby, what we looked into was that being conscious of how the axilla is overtreated by doing an upfront sentinel lymph node biopsy because of risk factors, we decided to capitalize on the possibility of MAG trace to reside in the tissue for a prolonged period of time, and we injected MAG trace during primary surgery, but we did not go and do sentinel node biopsy. So only patients that upgraded to invasive cancers would undergo a delayed sentinel lymph node biopsy, in which isotope and blue dye would also be injected. Now, mind you, this is not a mastectomy only study, so we used it both in breast conservation, simple and oncoplastic, but also in mastectomy. This strategy resulted in that approximately 80% of patients that would have undergone primary sentinel lymph node biopsy could effectively avoid it. And when we went back and did the delayed sentinel lymph node biopsy, what we saw is that the MAG trace outperformed the isotope and the blue dye, both after a mastectomy, but also after oncoplastic breast conservation. And this is reasonable because for you that do your therapeutic mammoplasties or mastopexes or perforator flaps, you understand that you have refurnished the breast and you have affected the lymphatic anatomy. This has already been disrupted. And the most interesting thing was that in the cases that the isotope was successful, the discordance was very high. So with other words, the isotope injected in operated breast tissue would find a completely different node than what MAG trace would find. And the MAG trace, I need to remind you, it had been primarily injected, so in non-operated, non-disrupted lymphatics. And I'm reminding you the fact that the discordance between the nodes that you would find with the isotope and the MAC trace in the primary setting was a risk difference of 0. So in that sense, we could understand that the accuracy of injecting the isotope afterwards and finding a node is probably not the node that you were looking for. This is a trial that gave us important insights, but being a feasibility trial, we wanted to explore the concept. Right now, we are performing the Sentinel 2 trial, which is a randomized controlled trial that aspires to see differences are adequately powered in the detection rates and the accuracy of delayed sentinel lymph node biopsy with the MAC trace against what we are doing outside the trial, which is inject isotope and hope for the best. Now, we pushed the delayed sentinel lymph node biopsy concept even further. So this is a study in which patients that were clinically N1 at presentation that would go and get neoadjuvant chemo would receive MAC trace either before or during or after neoadjuvant chemotherapy, depending on whether we wanted to monitor it with an MRI, and they would get isotope on the day of surgery. And what we wanted to see was whether the concordance between isotope and MAC trace would change depending on the time frame of injection. So more or less what we wanted to see is that if you inject it before neoadjuvant chemotherapy, will it be detectable afterwards? And if it will be detectable, will it find the same node? So is it accurate enough to be trusted? And what we found was that the concordance between MAC trace and isotope was not affected by the time of MAC trace injection. The detection rates were impressively high, and MAC trace was successful in 97.5% of patients versus 91% for the isotope. We had a median of 3 nodes against 2 for the isotope. Interestingly, the clipped node was magnetic in 94% of patients versus in 62% of patients for the isotope. And I think that this has to do with the fact that MAC trace is being uptaken in the nodal tissue by the macrophages. And this is something that if you do it prior to chemotherapy, does not have the risk of being affected by the fibrosis effect that chemotherapy will give to the patients. And interestingly, we had a 16% difference in the successful detection rate of metastatic lymph nodes. So this is something that one needs to decide for the future. And another thing about the future, and I think that this is something that will become much more relevant along with delayed sentinel lymph node biopsy in the era of sound and ensema, is that we found that if we use the artifact on the MRI, which is bad for the breast, but for the axilla, we could perform an MRI lymphography of the axilla after SPO injection, and the artifact over there will by definition be the sentinel lymph node. So in this phase 2 trial, the MAGUS trial, what we did is that we performed an MRI lymphography. The surgeon was blinded to that, and afterwards, with the results of the MRI lymphography, the radiologist would pick up the probe and they would do a focused ultrasound and they would go and do a core biopsy where they had signal. They verified whether there was magnetic uptake and brown color in the biopsy. And in that way, we had performed a true transcutaneous sentinel lymph node biopsy. The surgeon was blinded to the entire procedure, and afterward, the surgeons would go and do sentinel lymph node biopsy. In this phase 2 study, what we found was that the area under the curve for the MAGUS technique was 95.5%, and out of the patients that had metastasis in the sentinel lymph node, the MAGUS technique missed only one micrometastasis. All macrometastatic patients were found. So I think that this is something that will help us in the future to tailor a little bit more where we do things. I firmly believe that once we start implementing sound and ensema criteria more broadly, this is going to be the way to do things. We will be injecting SPO, we will be omitting sentinel lymph node biopsy, and if pathology comes back and generates questions about nodal status to drive treatment decisions, we will be able to do either a MAGUS or a delayed sentinel lymph node biopsy. And with that, I would like to thank you for your attention.
Thank you, Andreas. Brilliant, as usual. Nice history and overview of the alternative. I think leaves very little to ask in terms of questions, but there are a couple of questions which I've left open specifically on our, oh, some of them have disappeared now. So I think there's a common theme, and Candice has answered a few of them, is how do we avoid staining? Everyone's question is, how do we avoid staining? So let me start with Andreas, and I'll go to Candice, and I'll ask Mark.
So there is a very simple way. Let's just look at the physiology. A deeper injection will result to less skin staining by definition. When you perform the deeper injection, there are two things that one needs to take into account. The one thing is that if you flush it in, if you just flush it in, you do not control the dispersion, so you have a higher risk that this will be taken by superficial lymphatics by the difference of hydrostatic pressure when you're injecting. So a slow injection is less painful or less discomfortable for the patient, and it will give you better control. It will, moreover, limit the dispersion locally, which means that the footprint of the tumor and the footprint of the SPO will be the same. So you have a higher chance of removing the SPO footprint at the same time if your concern is that of the MRI artifacts. The other thing that one needs to realize is that if you go preoperatively, you do not need to massage. If you massage it, what's going to happen is that you will cause spread and you will cause discoloration that way. We are dealing with at this point in time in clinical practice, we are dealing with cases of discoloration. I already know we have a discoloration of 2.5%, and it is the case where the radiologist has injected, and you can see the tail of the fluid towards the skin, and that means that they just did a very hasty injection. But the takeaway message is that it is fully preventable. It is fully preventable. It's a matter of how you do it.
Candice, any tricks?
I would absolutely echo the slow, deep parenchymal injection. I think the deeper you get the injection, the better off. The other option is a superficial injection in skin that will be resected. Many of us are doing oncoplastic approaches and resecting skin along with underlying tissue. And if that skin goes, you can't stain it. I mean, you can stain it, but it won't matter. So that's another thing. And if you must massage gently.
Yeah, that's a very important remark. I would just want to highlight that if that skin is not resected but de-epithelialized, you will have MRI artifacts, and this needs to be taken into account.
Yes. Yeah.
Mark?
Yeah, I mean, once you have a staining, and this is my experience from the early days, then it will stay. So I have patients having a staining for 10 years right now. But I agree on what Candice and Andreas said, that don't massage. So if you plan your injection, your marking, and this is something what you are able to do, so you don't need a massage. If you inject it slow, this is the preferable way. And if you just stop your injection and you inject it once and then maybe some different injections in one, so not everything in a whole, then of course you will avoid with a deep injection the staining. So we don't see any staining now for the last 1.5 years when we changed from just to inject it in the breast to a more focused and then ultrasound guided what I presented in the video injection.
Another thing that is very important in this setting, and that might be of use, we have completed the prospective cohort study for oncoplastic cases, is that if you do it that way, you can very nicely combine it with a MagSeed. I'm talking about MagSeed because I'm thinking of one probe. I don't like to have a lot of gadgets in the theater. I don't like to have this for this and that for that, because I usually get confused. So what we do is that in the case of big lesions and stuff like that, we are discussing successful tumor localization, but we all know that it is never about the tumor, it is always about the margins, right? So the mag trace will create a very, very nice halo if you put it carefully in one point, but at the same time, if you have a complex lesion, you can just breadcrumb it around and combine it with a MagSeed, and that way you can bracket larger areas. And if you needed a fence, of many markers, then you can use one or two, which is much more sustainable in terms of costs, and then combine the rest with mark trace. And then in that way, you solve everything. You hit more than two birds with one stone, if one could say it like that.
Brilliant. And if you have in the 2 or 3% that you get staining, and I know Candice, you've answered this, but I just want the wider group to know this. Is there anything we can do to kind of get rid of that staining?
Not that I know of. I think neither blue dye nor mag trace staining, it's tincture of time. And I do think that most staining will resolve with time. There may be some patients who have a permanent residual stain. What I've noticed though, the more that we've treated these patients is as long as they know why it's there, it usually bothers us more than it bothers the patient.
Yeah, that's a
Agreed.
very good point.
We had a follow-up study with Frederick Wernberry, published back in 2019, where we followed different types of injection and staining over time. And what we actually saw echoes with what Candice said. But the most important thing, another insight, and we would not be aware of that if we had not had that data set, is that the persistence of staining is very, very proportionate to the damage radiotherapy does to the breast. So the more swollen lymphatics and the longer the staining will take to resolve. But the reason that I'm just sticking to the details is that this is something that for like Mark and myself that worked with the technique from the early days, this was a concern. This is completely preventable. So you don't need to be concerned about that, because as long as you do it correctly, you'll not have any problem with that.
So prevention is
don't inject it in the upper outer quadrant. I mean, this is what I was told. So just inject it, and then Andreas, what you said, and then you pull the needle out, and then you will lose, of course, spews. So therefore, I don't see it anymore. So
yeah. We don't see it either. I mean, you see the occasional patient that they have done this, because they're in a hurry. But the main message is that it is preventable. So it is up to us that do it, or our radiologists, to do it correctly and prevent against that happening. The MRI artifacts as well is something that I think is interesting, because just before we published the post-MAG MRI, there was a study from the Netherlands, and they had tried to kind of, avoid the challenge of overlapping signals between MAG-seed and MAG-trace by injecting it somewhere else in the breast. And what they found is that they had an artifact. So if you just inject it there and don't do anything about it, it has no reason to go away.
Okay.
But you can make it go away by just injecting in what you will be removing. So I think that, and this is something that the meta-analysis showed very eloquently. And the reason I believe in this paper is that the grade recommendations were performed by an oncologist, not a surgeon that is methodological trained, and the master himself, Torsten Kuhn. So we did not have, those that did the meta-analysis did not have anything to do with those that graded the evidence. I think that everything highlights towards that a preoperative peritumoral injection is the way forward, because you have no compromise in the outcomes that you are interested in. You get the best of it without any of the bad. And moreover, it seems to be much more cost efficient regardless of the system that you work with. Because I guess that even in the states where things have to do with reimbursements, right, Candice? This is something that once standardized, you will get a code for that, and that's the end of it.
Yep.
That's how it works.
Yeah.
Now, very quickly, there was some discussion on the forum, I mean, on the question answer. You've answered it, but again, I want the wider forum to know this. Is if you're using the Gen 2, especially with the Gen 2 Sentimag probe, the Gen 3 is not a question, but the Gen 2 probe, if you have a mag seed and a mag trace, and you don't have an ultrasound capability of injecting it retrotumorally, where would you inject it so that there is no crosstalk between the seed and the spear?
So if you need to localize, I guess that if you don't have an ultrasound to do it by yourself, somebody will do it for you. So you can ask the person that will do it for you, once they have put the mag seed in the tumor, to put the mag trace behind the tumor. It's the easiest thing. Now, the mag total trial what we had is we had a composite primary endpoint, and that was not only re-excision, because re-excision is the yin. The yin, you can, if you want to avoid re-excision, then you do quadrantectomies in everybody or mastectomies in everybody, and then you avoid re-excisions, right? But we also had the resection ratio. So we had calculated the volume that we wanted to remove, and that was the ratio of what we removed against the volume that we wanted to remove. And it had to be as close to 1 as possible. So we had the yang. So we stretched ourselves that way. So what we found is that the guide wire, and interestingly, if you do a posterior injection of MAC trace, you actually don't see any discoloration if you have a guide wire there. So you are not guided by the brown color as simply as that, right? So the resection race, and that was an equivalence trial with a very tight two-sided margin. The resection ratios were completely comparable. So in the per protocol analysis, you had 197 for the guide wire and 196 for the MAC seed. So the concern of the overlapping signal, I understand the concern. I had the concern myself when we started doing the trial, but now we have a pragmatic trial that had even residents doing surgery and would not see any problem. And the reason for that is that you will go with your probe up from above, right?
Yeah.
The MAC seed never loses focality, even in the brown tissue, right? So that's my 5 cents on that.
Perfect. Now, just one last question, and I'll start with Mark first. If Santa Claus came early in 2025 and said, Mark, one technique to do sentinel node biopsies, what would be your choice?
At the moment, the first choice would be MAC trace, and then it would be ICG, because I do see some obstacles and some disadvantages in ICG. For example, if you perform a nipple-sparing mastectomy and you want to perform the sentinel biopsy directly from the same incision, what I really like, then of course you have to go from the back, and then this is really difficult for ICG. So I would say you have more options with MAC trace. You have the stability, as I said, marking days. You don't have to do anything in the OR. The equipment is cheaper. So therefore MAC trace first, ICG second, and then third, get rid of technetium.
Brilliant. I think, and the reasoning that you've given is perfect. I think that's very nice, especially for the nipple sparing mastectomy. Candice, anything else to add to, or what would be your preferred?
No, I would say I am not as facile with ICG, and I would fight with my plastic surgeons for the camera. So MagTrace is the easy winner for me because I can use it in all settings, including outpatient surgery centers where we have no radiation license, and where an anaphylactic event would be catastrophic for them. So I would say MagTrace, secondary to that would be technetium blue dye, and then ICG after that.
I'm not going to ask Andreas because I know the answer.
Yeah, well, I mean, I have been very open, and it would be very hard to hide after doing 12 trials on that. But a thing that I would like to add, because I saw that in the questions or the chat, there are people that are discussing the risk of allergic reactions with MAC trace. So we have been doing surveillance for patients in trials and in clinical practice. One time we saw a vasovagal reaction, and the patient was taken to the A&E to see what had happened, and they just did some toxicology levels in that, and the patient was allergic to local anesthetic. There are no documented anaphylactic reactions from SPIO. The only thing that I do not know, I mean, I had this discussion with Stefan Pepke, who is also a gynecologist. Pregnancy, what do you think, Mark? Is it an issue?
No, it's not an issue, but we have to collect data, of course, and this is what I had to focus on when I worked on this chapter in our treatment recommendations of the AGO. I didn't find any data. Then I asked the company, and they said no, pregnancy was an exclusion criteria, so therefore we don't have data. I wouldn't see any issue. I don't see an issue for ICG, but it's not approved in Germany, so therefore I think these iron particles that they don't affect pregnancy. But I think at last we have to collect some data.
Agree.
Very,
And the
very
other thing that I
important.
would like to highlight in terms of, when is something ready to launch? I think that these are techniques that are ready to launch. And there is another thing that we need to be aware of, especially referring to the ideal framework. So the ideal framework states very, very clearly that if you have a device or a technique that does not make superiority claims, you do not need a head-to-head randomized control trial to show benefit. So, and with the detection rates that we have on those levels, so you have detection rates of like 98 and 99%, right? You cannot demonstrate a clinically meaningful difference. And if you wanted to do a statistically significant trial, I have done the calculations myself. You would need approximately 32,000 patients. So if anybody is curious or ambitious, be my guest. I know I'm not. That's what I mean. That's what I
So
mean.
we've got to 8 o'clock, and the time has really gone past quickly with fantastic discussions, great presentations. Thank you, Andreas. Thank you, Mark. Thank you, Candice. We have 2 more poll questions for the delegates who've attended. We had over 300 attending. Thank you very much. So if we can get these 2 poll questions up, and then we won't come back, we just say goodbye. We just want to see what kind of conversion we've got. The first question is, based on the discussion today, going forward, I may consider using delayed sentinel biopsy in selected cases, so not all, of patients undergoing a mastectomy, which is a simple mastectomy, for DCIS. It could be a skin sparing, could be nipple sparing as well. So do you agree that you would consider it? You totally dismiss it, or you still need more convincing? So this is the true test of our 3 speakers. Right, let's get the answers, please, Maria. Great. So we've managed 71%, 20 undecided, so they just need a little more persuasion, I think. 9% disagree totally, which again can be debated. But when we're talking about case selections, and that's a totally different webinar altogether, I think we will be able to convert those. And the next question is, based on the evidence presented today, I believe that a magnetic tracer that provides both a visible and audible guide to sentinel node biopsy is non-inferior replacement to the current gold standard of Tc99. I mean, this is a no-brainer, but we still have to ask this. Agree, disagree, or still undecided? We'll give you some more time to answer this. Right, Maria, can we have the answers, please? Fantastic. So 7% need more evidence. I don't know what more evidence. I would advise you to read all those 12 trials that Andreas mentioned. Undecided ones, yes. Obviously, if you need more persuasion, please again read the data, analyze it, and it has to agree with you in your setting. So, but 80% agree. So if given an alternative, I think that's a very good, I think, turnout that we would want from today's webinar for all the 3 speakers. So thank you again, Candice, Mark, and Andreas, and thank you, ESSO, for hosting this, and a big thank you to Endomag for making this, sponsoring this event, making it free for everyone. Good night, wherever you are in the world, or good afternoon in the US.
Thank
And bye
you.
for now.